So thank you everyone for coming along to this first of a series of webinars. My name is Barbara Henrossi. I'm Professor of Primary Care and Public Health at Newcastle University and Director of the Healthy Ageing Policy Research Unit. The work you're going to hear about today has been produced by a collaborative team of researchers from the Universities of Newcastle, Manchester and the London School of Economics. Between 2019 and 2023, we were the Older People and Frailty Policy Research Unit, but from the beginning of this year we've become the Healthy Ageing Policy Research Unit. We're one of 20 units funded by NIHR to produce independent research that can inform policy decisions. So our work is a mixture of commissioned research mainly from the Department of Health and Social Care or NHS England, or projects we've proposed ourselves. And the overarching aim of all our work is to support policymakers to improve the health and well-being of people in mid to later life. And we have a strong focus on inequalities. I can hear a lot of people coming into the webinar as we're talking, and our website has links to all our reports and publications and more information about the unit. We'll post the link in the chat during the meeting. In today's webinar, you're going to hear 4 short presentations for around 10 minutes each on the broad topic of frailty, falls, receipt of care and hospital admissions. You'll hear the term frailty a lot over the next hour, and we will be defining it at the outset, but we acknowledge its limitations. We're using concepts that are well established, but we know that frailty isn't necessarily a term that's favoured by older people, and it doesn't include issues that may be particularly important to individuals, such as social relationships or social circumstances. Each of our talks should be, as I said, under 10 minutes, and we hope to have the time to respond to 2 or 3 questions after each talk. If you look at the menu bar, you'll see there's a chat function. Please post any comments or reflections there. And we'll add the links to any relevant reports and our website address. If you want to pose a question, then please use the Q&A button. If you hit that button, you'll be able to type in a question, you'll be able to view the questions other people are asking and also vote on them. And you do that by hitting the thumbs up below each question. Depending on time, as I say, we'll cover 2 or 3 questions, but any that we don't cover, we will circulate a response to anyone who's registered to attend the meeting, along with a link to the video of the session. So that brief introduction, it's great to see so many people here and still arriving. I'm going to hand over to our first speaker, David Sinclair.
Hey, hello everyone. Thanks a lot for coming. Just going to share my screen now. Is that okay for everyone? Okay, great. Okay, so this first talk is going to be on kind of frailty and its kind of distribution in England as you go to different kind of parts of the country, different local authorities. How does the prevalence of frailty change based on the people who are living there? And this is work that I've done at Newcastle University with my colleagues in our Policy Research Unit across Manchester and LSE. So frailty, it's kind of defined by Age UK as someone's overall resilience and how this relates to their chance to recover quickly following health problems. It's kind of been used in kind of academic research for a couple of decades now, and there's kind of a lot of research that's showing how it's associated with adverse health outcomes such as hospitalisation, admission to care homes, mortality, needing, medications, all these kind of things. There's a lot of research showing that, even though it's kind of not necessarily an easily defined concept, the way we measure it is kind of associated with all these negative health outcomes. So that's why it's quite a useful concept for us to use. And we know it's associated with poor quality of life. But what we don't really have a good handle on is, how is frailty distributed kind of geographically? We know kind of its association with things like deprivation, but we don't know its association with geography in the same way. So we wanted to figure out how does how does it vary, and how does it vary especially by kind of area type, so urban v rural areas or inland v coastal areas. Are we seeing different prevalences in frailty between these different area types? And there's a few different ways you could go about doing this. Population screening would be one robust way of doing that, but this would be a bit time consuming, it'd be expensive. And also, older people don't always kind of consider themselves or identify themselves as frail. So that would be a kind of presenting difficulties here. So we wanted to come up with a quicker and cheaper method to try and figure out where frail people or people with frailty might be located in England. And to do this, the first thing we needed to do was come up with our way of measuring frailty. And there's quite a few different ways of doing this. Kind of one of the advantages of frailty is that depending on the context that you want to work in or you have your data for, there's different metrics for how you go about measuring frailty. But one of the ones that's kind of very widely used, especially when you're using survey data, is something called a frailty index or the cumulative deficit approach. And with this approach, you basically say, okay, what are all the things that you have data on that relate to the aging process? And these are things that are also associated with someone's health and will tend to accumulate as people get older. And so these can be things to do with someone's mobility, such as their ability to walk 100 yards, climb a flight of stairs by themselves, activities of daily living, so things like being able to feed themselves, being able to get in and out of bed by themselves. Also, like diagnoses and diseases such as heart disease, chronic lung disease, decline in sensory function, so hearing loss, sight loss, and cognitive function, if that's declining. So you can take all these kind of deficits and see how many does somebody have. So if you had an imaginary person and they had, you asked them about these 9 things here on the slide and say that they have problems climbing a flight of stairs by themselves and they have chronic lung disease, then you say, oh, you've got 2 of these 9 deficits, so we're giving you a frailty score of 0.22. And now ideally you'd have more than 9 deficits, you want to have at least 30, but kind of the more you can include, the more useful your measurements will probably be. But you give everybody a frailty score, and then you can like categorize people into different levels of frailty, depending on what their score are. And like these kind of cut points, to an extent, they're a little arbitrary. The key thing is that the higher somebody's score is, the more frail they are. But you can roughly group people into different groups. And for this work, we said somebody who got a score of more than 0.36, we said they're frail. If their score's between 0.24 and 0.36, they're pre-frail. And if it's less than 0.24, they're robust. But the key thing to bear in mind is the more deficits somebody has, the frailer they will be. And so that's how we measure frailty. We now want to have some data for which we can take these measurements on. And for this, we used ELSA, the English Longitudinal Study of Aging. This is a really useful resource for health and lifestyles of older people. It's been running since 2002. They ask their cohort every 2 years, lots of data about their health, their daily activities, their health behavior, their economic circumstances, socioeconomic background. And you can use this as a treasure trove of information to kind of study the health of older people. We used Wave 8, which was the latest wave of ELSA data that was available at the time that we were doing the study, that we could link to some key socioeconomic data. And so we looked at people over the age of 50 within ELSA, which is everybody in ELSA, and that's just over 8,000 people that we could look at, how frail they are. And so when you look at data from ELSA, you can see, everybody's anonymized, but they have an ID number. And then you can put them into an age group, a gender, and we use their deprivation quintile. So the English Index of Multiple Deprivation, it's the official government measurement of deprivation. And so we divided everybody up into quintiles. So you've got the 20% most deprived people in the 20% most deprived areas, then the next 20% most deprived areas, all the way to the 20% least deprived. And then we could also take a bunch of questions that are in the ELSA survey on people's health and their disability to assign a frailty score to everybody based on our frailty index that we came up with. And then we can take all this data, apply a logistic regression to that data, and basically we come up with a formula for the probability of somebody being frail based on their age, their gender, and the deprivation in the area that they live. And so you can take that, you've got this formula, and then you say, well, we can take data from the Office of National Statistics and say, well, in each local authority, we know how deprived that local authority is, we know how many people, each gender and each age group, and then we can kind of work through these probabilities to figure out, okay, of the older population who live in each local authority, how many of them do we think are frail? And when we do that, we get a map that looks like this. So this is a map of all the local authorities in England, and it's showing what is the what do we expect the prevalence of frailty to be among the population over the age of 50. So not the total population. This is specifically looking at within their older population, how does the probability of somebody being frail differ? And we can see there's kind of clear geographic differences here. In the north, there's a lot more, the prevalence of frailty is much higher, especially in the M62 corridor, in the northeast, but also in the West Midlands around Birmingham, and some parts of London. We can see that generally in the south, it's frailty prevalence is lower. And also we've got this contrast between the coastal areas and the inland areas, where the prevalence of frailty in the coastal areas seems to be higher. And in fact, if we group our areas and say, okay, which are the urban ones, which are the rural ones, which are coastal and which are inland, and see how does prevalence of frailty vary across these areas, we get a plot like this. So this is a box plot showing rural, urban, inland, and coastal areas. This kind of thick horizontal line on each one. This is the kind of expected prevalence of frailty. It's the median across all of the areas that correspond to that type. And then the notch here is the confidence interval on that. And so you can see there's a clear difference. Urban areas have a higher prevalence of frailty than rural areas, according to our estimates, among the older population. And also coastal areas have a higher prevalence of frailty than inland. And overall, coastal areas seem to be have the highest prevalence of frailty of all the area types, even more than urban areas. So to kind of summarize that data, we're seeing a large geographic variance in the prevalence of frailty. Coastal and urban areas have the highest prevalence, and this is key, especially amongst the coastal areas, because as we're going forward into the next couple of decades, we were expecting the older population to be increasingly concentrated in rural and coastal areas. So an older population in general and the risk of frailty increasing in coastal areas suggests that we need to really think about targeting resources to coastal areas, as they're probably going to have the frailest old population going forward, and that kind of difference to the other area types is going to keep on increasing over time. And we've also demonstrated a method here of estimating the distribution of frailty in a population. So this could be applied to other countries, for example. If you want to know a bit more details, this is published in the Journal of Frailty and Aging, and it's also featured in the Chief Medical Officer's annual report from last year. But thanks a lot.
Great, thank you, David. Can I just encourage everyone, if you would like to pose a question, to hit the Q&A button and put your question in there. As we haven't had much activity there to date, and David is going to do a second presentation, I invite you maybe to go straight into your second talk, David, and we'll take questions after that.
Yeah, okay, I can do that. Let me get the new slideshow up. Does that look all good? Okay, cool. Okay, so this second talk is taking this idea. So we kind of know where frailty is now, but what we don't really have a good understanding of is how frailty and the risk of somebody becoming frail, kind of how that relates to whether they're receiving care or whether they're receiving enough care for what they need. So this is a study we did to try and understand that. And so we know that we've got an aging population. We know health and social care demand is rising, and this is going to be one of the really big challenges now and for the next couple of decades. And dealing with our aging population, how do we make sure that there's enough health and social care kind of service? You know, how can there's a high enough service to cope with the aging population and provide people with the care, health and social care that they need? And we also know that people who are frail disproportionately need care. You know, as I said before, they're more likely to be hospitalized. They're more likely to end up in a care home. They're more likely to become disabled. So this is a high-risk population to kind of focus on and understand how can we kind of hopefully decrease the risk of somebody becoming frail or increase the age at which they become frail, so that their overall lifetime need for health and social care demand isn't going up. But we need to understand how this relationship between care and becoming frailty, kind of what are the associations there, if any. And to do that, we used ELSA. So again, the English Longitudinal Study of Aging. And this time we looked at it longitudinally. So we took all the data from 2002 through to 2019. So that's covering 15,000 people. And they're asked every 2 years about their health and their lifestyle and their kind of socioeconomic background. And we could take that and kind of come up with what we call a multi-state model. So this is kind of a simplified way of saying everybody is occupying one of these frailty states or they're dead. So, you know, people who are either robust, pre-frail, or frail. And as time goes on, they can move between these states following these arrows. And so you might have somebody who's interviewed in the first wave of ELSA and they were robust, and then maybe they were still robust in the second wave. In the third wave, they might have been pre-frail. The fourth wave, they might have become frail. And then maybe in the fifth wave, they're dead. And so you follow somebody's health and their frailty, how that trajectory changes over time. And you follow everybody in the ELSA survey to get an understanding of what is the risk of people moving between these different frailty states based on things like their age and gender. And how do we try and make sure people spend longer in this robust state and less time in this frail state? And so we wanted to understand how kind of these risks of transitioning between these states varies, and how that risk varies based on not just age and gender, but kind of key kind of factors, such as if somebody's receiving care, how does that affect these risks? What happens if they report an unmet need for care? So they say they have trouble getting up and down stairs. They say they have trouble feeding themselves or cleaning their house or something like that, but nobody helps them for that. They have kind of this unmet need for care, and how does that impact their trajectories between these states? And then also kind of key socioeconomic factors such as wealth, deprivation, years of education, and marital status. And so we can take all that data from ELSA, following how everybody changes over their lifetime between these different states, and relate those risks to their socioeconomic background and whether they're receiving care and whether they need more care than they're receiving. And when we do that, we run our model, we get our results, we get something that's called a hazard ratio. Now, a hazard ratio, it's similar to an odds ratio, if you haven't come across it before. It's basically representing an instantaneous risk of somebody making a transition and how that varies between different categories of people. So what this plot here is showing is the hazard ratio of women and men transitioning from pre-frail to frail, and how that hazard ratio, that risk of that transitioning occurring, increases for somebody who receives care. So these kind of purple dots, like people get care receipt, compared to somebody who doesn't receive care. And so the risk of somebody who's getting care, making this transition from pre-frail to frail, is about 2.3 times greater than somebody who's kind of not getting care. So that's a massive difference. So it's kind of showing us that people who start receiving care are kind of a really high risk of becoming frail, and potentially they should be a group that we should target interventions at, try and identify early, because those are the ones who are at the biggest risk of becoming frail. But we've also got wealth here. That's what these yellow dots are, and it's showing that because it's less than 1, the risk of somebody making this pre-frail to frail transition decreases the wealthier somebody is. So wealth we measured in quintiles. So this is just the effect of going up 1 quintile. So maybe comparing the second least wealthy to the most least wealthy, and how that risk decreases by about 0.8, but that's going to be cumulative. So the wealthiest compared to the least wealthy, there's about the hazard ratio, I think, is about 0.4, the cumulative effect as you go up these wealth quintiles. So a really big socioeconomic effect there with wealth, or at least a strong association. And if we bring in our other socioeconomic factors we looked at, we can see that a very similar pattern. So people who are married have a reduced risk of going from pre-frail to frail. The more education somebody's had, that risk is going down as well. And people who live in less deprived areas, that risk of going from pre-frail to frail is decreasing as well. So this, care is a really strong effect, but also these kind of socioeconomic factors seem to be really strongly associated with the risk of frailty. Now, interestingly, this is when we do it looking at care receipt, but the second plot here is showing what happens when people report an unmet need for care. And so in the men, you can see a very similar pattern to care receipt. The men who report an unmet need for care have an increased risk of going from pre-frailty to frailty. But for the women, that risk is not evident at all. There seems to be no association there between reporting an unmet need for care and an increased risk or decreased risk of moving from pre-frail to frail for women, unlike men. So that's quite an interesting gender difference that's come out of this analysis. And as well as showing hazard ratios, we can maybe show these results in a bit more accessible way with probabilities. So what this plot here is showing is, so for a man who's robust and is at age 50, what is the probability that they'll be in each of these states at different ages as they age? As they get older, what's the probability of being in each state? So a man who's age 50 and robust, by the time he gets to age 60, there's quite a small chance that he'll still be robust if he's in the lowest wealth quintile and he's receiving care. Whereas there's, about a 40% chance that he'll be frail within 10 years and a 25% chance that he'll be dead. And then we can compare that across these kind of socioeconomic categories and care categories. So this is, the least wealthy who receive care, the most wealthy who receive care, the least wealthy who don't receive care, and the most wealthy who don't receive care. So you can see people who are very wealthy and don't need any care, they're far more likely to still be robust, even into like their 90s than, say, somebody who is wealthy and receives care, or somebody who's in the least wealthy quintile and receives care. But the thing that kind of jumped out to us in this analysis, comparing the least wealthy who don't get care to the most wealthy who do get care. So you'd imagine somebody who gets care probably has things, some sort of health problems. They're getting care for a reason. But the probability of them being in each of these states over time is almost identical if they're in the wealthiest group to those who are in the least wealthy group who don't need any care. So this is kind of telling us that even though receiving care is really important, wealth seems to be just as important a predictor of which state somebody's going to be in and a risk of frailty over time as receiving care is. And that's true for men. And then this plot here above is now for the women, and it's a very similar story, similar patterns between the least wealthy who don't receive care and the most wealthy who do receive care. So to summarize that, receiving care increases somebody's susceptibility to frailty and lowers their chance of reducing the level of frailty. But wealth is equally important as care receipt in predicting frailty. And then we've got this interesting gender difference between men and women, that unmet needs for care is associated with frailty for men, but it's not for women. Okay, thanks a lot.
Thanks, David. for both of your talks. We have one question in the chat, which is about your measure of frailty. So it was observed that your people can move both ways, in and out of frailty and pre-frailty, whereas the traditional model of frailty isn't that one way. So would you like to just say a little bit about the measure of frailty that you used here?
Yeah, so we use the frailty index cumulative deficit approach. So you ask somebody at a period of time about 30 or more different things that could be wrong with their health, see how many they have, give them a frailty score. And if they've got so many, you say they're frail, and if they don't have that many, you might say they're pre-frail or robust. And traditionally, all these deficits are things that would accumulate over time, and the older you are, the more likely you are to have them. But it doesn't have to be something that people can't get rid of. Somebody who has trouble walking 100 meters, somebody who has trouble going up downstairs, that might only be a temporary thing, and they might then recover. And there's not a hard and fast rule that these have to be permanent things. There is one measure of frailty that's used called the e-frailty index. This is often used in primary care and associated with electronic medical records. And the way the e-frailty index is constructed, that's always, if you've had it once, then that's you've got that forever. And that doesn't go away. And that's kind of an artifact of the way that Andy Clegg, who put this together as one of our colleagues on the Policy Research Unit, it's kind of an artifact of what Andy had to do with the data that was available and kind of some of the limitations of primary care records. But I think that might be changing. I think at some point this year, there's going to be an update to the e-frailty index, and it's more likely that there might be a time limitation, but I'm not certain of that yet. I don't know what the latest things Andy's doing on that are, but in general, you don't have to stay frail. You can recover from it. There's lots of metrics of frailty that let you recover. And I think that's a good sign. I think that reflects, what we see in data from things like ELSA, that people don't always stay frail.
Thanks, David. Apologies that the Q&A hasn't been accessible for some people. So I think we'll just take one more question. Please feel free to put questions either in the Q&A or in the chat if you have access. So question from Emily. Do you know why the unmet needs for women doesn't affect their trajectory like men?
I don't. I think it's a really interesting
question.
Something that I wasn't expecting at all of this data. And I don't know if there's what that's got to do with, what that's showing about how women and men perceive their health differently as they get older, or kind of their views of needing help, to kind of our stubbornness for independence. I don't know if there's going to be an association there with the fact that often you'd find that maybe women might support their husband in older age and provide a lot of help, but that might not be the other way around. We also do tend to see differences in frailty and how that affects men and women. So generally, and in lots of measures of kind of healthy life expectancy, women will tend to gradually decline over time. So women live longer, but they'll also live a lot longer with worse health. Whereas men typically will tend to stay relatively healthy until much closer to the end of their life, and then their health will decline relatively rapidly at the end. So that might also be a factor here, where it's kind of women who are spending longer in poorer health, and maybe that's not affecting their overall perception of whether they need help or not. And I'm not entirely sure. I don't really have the data. I think this is something that needs a more of a qualitative analysis rather than a quantitative analysis, but it's a really interesting question that I'd love to know the answer to.
Great, thanks very much, David. We'll move on to our next speaker. Thank you for the interesting questions that are coming into the chat, and also the really helpful links. Tom's put a couple of really useful links in to the chat, so just draw your attention to those. And next speaker, Asri.
Thank you, Barbara. I will share my screen. Yeah, is it okay now? Thank you, everyone. Today, I would like to present about our research on the association between frailty, care receipt, and unmet need for care with the risk of hospital admission. So, previous study has highlighted the findings that frailty is associated with the increased use of health and social care. While our prior study, available in the website of the NIHR Policy Research Unit, Older People and Frailty, estimated the number of adults aged 65 years and older with pre-frailty were 1.6 million and with frailty is around 0.7 million in England in 2018. However, the most recent survey for the same age group shows that only 500,000 individuals in England receiving formal care in the same year. And this graph is looking at how the prevalence of pre-frail and frail among older people and care recipients in local authority. Our prior data does highlight that there is probably the mismatch between frailty and the receipt of care. Our study does aim to understand how the care receipts and unmet need for care among older people with different frailty status are associated with the risk of hospitalization, including unplanned admission for the hospital for any cause and for condition associated with frailty, specifically for falls and fractures. We use 3 data sets combined into one data set. The first one is the English longitudinal study of aging, and then we merged that with the census of public hospital records in England, which called hospital episode statistics, and the mortality data from the Office for National Statistics. We use information from 2,656 adults aged 60 and older who participating in ELSA waves 6 into wave 8. To measure the frailty index, we use the same measurement have been explained by David before, which consists of 60 deficits, include the multimorbidity or disease state, symptom and signs, disability and disability. And we then divided the score into 3. Frail if the score is higher than 0.35, pre-frail if the score between 0.25 into 0.35, and robust or no frailty if the score less than 0.25. For the care receipt, for the first one, we divided the care receipt into 3. Based on the frequency, we categorize the respondent into receiving high levels of care if they receive care on using the toilets, getting in and out the house, eating, bathing, walking across the room, dressing, or having meals on wheels. Why we categorize the respondent as receiving low levels of care if they receive the care on the grocery shopping, house of garden work, managing money, climbing the stairs, taking medication, walking 100 yards, or attending a day center. And the final categorization is if they receive no care. The unmet need for care is based on the self-reported unmet need for care. So we categorize the respondent as having unmet care needs if they're reporting that their care needs is unmet, and met care of needs, and the final categorization is did not receive any care. For the statistical analysis, we did a survival analysis and employed the competing risk regression analysis using fine and gray analysis, looking at the effect of the mismatch between levels of frailty and receive of care on each hospitalization category, and the competing risk is mortality or death. We found that approximately 17.7% of the respondents were frail and 40.6% of the respondents were pre-frail. And for the frequency of care here, based on the ELSA with 6 as the baseline, around 10% individuals reporting that they have high levels of care, 15% receiving low levels of care. Very high proportion, quite significant proportion, which is 70%, 74% of people who were frail, they receive high levels of care, while 38% of them receiving low level of care. Around a quarter of people who are pre-frail receiving high level of care, and slightly higher than half of them receiving low levels of care. Moving to the need for care, around 7.7 individuals reporting that they have unmet need for care. High proportion of them are those who are frail, so around 67% respondents who were frail, they're reporting that they have unmet need for care. This is around twice higher of the proportion compared to the people who are pre-frail, which around 31% of people who were pre-frail reporting having unmet need for care. When we look at the association between the frailty status and frequency of care and unplanned admission in the left graph here, we can see that being pre-frail is associated with the higher odds of having unplanned admission. The same thing, the people who were frail, they have around 2.5 higher odds of being admitted to the hospital. Receiving infrequent care was associated with 1.19 higher odds to have unplanned admissions, while the people who receive frequent care, this is the odds ratio is a bit higher, so they have 1.29 higher odds of having unplanned admission. Moving to the need for care, the people who reported that their care needs met, they have 1.22 higher odds of having unplanned admission, while having or reporting unmet care needs have no association with higher odds or lower odds of being hospitalized. When we look at each of the hospitalization due to falls and fractures, receiving care is associated with 1.3 higher odds of being hospitalized due to falls, but there is no association between receiving care and hospital admission due to fractures. So as the conclusion, we know now that frailty is associated with the increased risk of hospitalization. As frailty is potentially reversible health states, so early screening, timely diagnosis, and effective intervention at early stage could be effective strategies to reduce or delay healthcare or hospital utilization. We then also found that older people with frailty or pre-frailty who already in receipt of care are at greater risk of hospitalization. This finding suggests that this is a group who may potentially benefit from more detailed assessment and targeted or personalized community-based intervention with aim to reduce their risk. Thank you. And I return it to Barbara.
Hey, thank you. So I don't think we have any specific questions at the moment. So I think what we'll do is move on to Katie's the final presentation. And then if you have any questions for Asri about her research, then please post them in the chat or the Q&A, whichever is easier. So Katie, this is the final of our 4 presentations. Thank you.
Thank you. I'll just share my slides now. Great, can you see that? Thank you very much for the introduction. So I'm here today to present our work on frailty trends, titled A Prospective Analysis Examining Frailty Remission and the Association with Future Falls Risk in Older Adults in England. My name's Katie Davis and I'm an academic GP registrar working in Manchester. I'm here today on behalf of the Policy Research Unit to present our work in this area. This study aimed to assess frailty trends, so I'm just going to start by discussing definitions around this. Thank you to David for already defining some of the terms, for defining the term robust, pre-frail and frail, and also discussing the definition around one of the clinical frailty scores we often use, the frailty index. I'm just going to touch for comparison on another clinical frailty score, which is commonly used, the frailty phenotype, which is another way of measuring frailty. This score defines frailty as having 3 out of 5 criteria. These include slow gait speed, low energy expenditure, self-reported exhaustion, unintentional weight loss, and weak grip strength. So in terms of frailty, we often define it as a transitional state in which individuals decline from a state of robust to reduced functional ability with this prodromal state of pre-frailty, which was discussed previously. However, there has been some research to suggest that despite this idea of a decreasing reserve, it may well be a state which could be reversed. I've included 2 studies here, which are both meta-analyses, which mean they total the findings of multiple studies. Both studies look at frailty trends over an average follow-up period of 3 years. One uses the frailty index and the other uses the frailty phenotype. And both showed that improvements in frailty status were actually possible. So our research builds on this idea, asking whether frailty remission can be sustained for longer and whether this can affect future outcomes such as falls risk. So why is this important? I think this has already been discussed, but I'll go over this briefly. Frailty is associated with an increased risk of falls. If you're frail, you're more likely to be hospitalised. There's an increased mortality risk, and both frail and pre-frail individuals have an increased risk of multiple falls. So I'm just going to discuss what we did within our research project and how we did that. So we looked at natural frailty remission, where individuals are able to naturally improve their frailty status without any intervention. And we looked at 3 time points over a 5-year period. We then followed up participants over a further 10-year period to assess their future falls risk. We also used the English Longitudinal Study of Aging, ELSA, and we observed participants over the age of 50 years. You can see a figure there which shows the data collection within ELSA, demonstrating the years that we discussed previously, so from 2002, and we used until the data that was available at the time, which was wave 8 in 2016. You can see from the figure that data was collected through questionnaires and interviews at every wave, and the corresponding wave for each year. And there was also a nurse visit to every other wave. So I'm not expecting you to be able to see these slides very well, but it's just to give you an idea about the components we used within our frailty index to make up the frailty score. We used 59 physical, functional and psychological deficits. I'm hoping you might be able to see some of them there, but there's conditions such as hypertension, angina and heart attack, and activities of daily living like difficulty walking 100 yards and difficulty sitting for 2 hours. And there's a few more deficits there on this next slide. We then grouped participants, so we totaled their and summed their frailty index score, and then we grouped participants into defined cutoffs, as previously discussed, for those who were frail, pre-frail and robust across each of the waves. This figure shows grouped trends that we use within this study. We grouped 3 groups. We can see the middle group in green there, those individuals who improved their frailty status from wave 1 into wave 2, and they improved again further into wave 3 or sustained this into wave 3, showing improvement over 5 years. And that group's in green, and we compared them to those who remain robust and those who remain frail. So you can see both of those trajectories on this figure as well. We followed up these groups over waves 3 to wave 8 to assess their future risk of falls. We used Cox proportional hazard modelling. This allowed us to develop a model of risk for those 3 groups and the risk of those developing future falls. We wanted to ensure that our results adjusted for any factors which could have impacted those. So we adjusted for variables such as gender, age, marital status, smoking status and wealth. So just moving on to our findings. Of the 2,564 participants we included, we found half remained robust. We found a quarter of participants remained frail. And in fact, we showed 15% of people were able to improve their frailty status naturally and sustain this over a 5-year period. The average age of participants within the study was 66, and we found 549 participants reported a subsequent fall. You can see some of the study findings here. This is a Kaplan-Meier survival curve. This essentially shows us a way, shows the fraction of people who had a fall as we followed them up over a 10-year period. The bottom line you can see here shows time and we use study wave, and the top line shows the proportion of people who had a fall. You can see the group with natural frailty improvement in blue here, and those who remained frail in green. And you can see that those who had natural frailty improvement had a lower risk of falls compared to those who remained frail. So why are these findings important? We found that natural frailty remission is possible. 15% of older adults experience persistent and sustained improvement in frailty status over a 5-year period. To our knowledge, this is the first study to measure associated outcomes such as falls after frailty remission. We showed reduced falls in those with frailty remission compared to a frail group. Our results suggest interventions aimed at maintaining a robust function are important, but so is reversing frailty. Thank you very much for coming and listening to me today. I'm more than happy to answer any questions. What I hope you take away from today's talk is that although frailty is typically thought of as a progressive decline in function, we've shown natural reversal of frailty is possible with a reduction in future falls risk.
That's great. Thank you, Katie, and to all our speakers. I think we just had one question pop into the chat there. A question from Carmel Jones on, is there any data on interventions that support the reversal of frailty?
To be honest, I'm not particularly sure about that area myself, but I think obviously that's an interesting thought looking forward from our research.
Okay, thanks. So I think in view of the time, apologies. In view of the time, I'm just going to say huge thank you to our presenters. Next month, our webinar will be on a piece of work that's been led by our colleagues at the London School of Economics, looking at preferences for new models of care post-pandemic, particularly focusing on people with high care needs. So please join us for that. We will be circulating a link to the video, and also we'll respond to the questions that we've overlooked during this session. So thank you to our audience, and please consider joining us again next month.